All right, next looking at traumatic brain injury. So a traumatic brain injury is an acquired injury to the brain where there has been some type of force that causes damage to the brain tissue. Again, these injuries can be classified based on severity. We're going to go through the severities and kind of discuss what they mean as far as the range of damage that takes place and how the individual will usually be treated. Brain injuries are going to be usually graded in the emergency room. And there's a lot of different grading scales. Typically, again, the grading scales look at, did unconsciousness happen? If it did, how long did it last? And then they look at verbal, motor, and eye-opening response to a stimuli. The other way that we kind of look at traumatic brain injury is if it's a closed head injury or an open head injury. So a closed head injury is when there's no trauma to the skull. So in other words, someone hits their head or gets hit in the head by an object. There's no trauma to the skull, but there's still damage to the brain tissue. And usually in those circumstances, the damage is more diffuse. And the symptoms that they experience are going to be based upon more what kind of widespread damage to the brain. Whereas with an open head injury, when the skull is actually penetrated, there's going to be damage specific to the specific region of the brain tissue where the penetration of the skull had taken place. So now we're going to look at kind of the way your textbook kind of classifies the traumatic brain injury. So mild traumatic brain injury, or at least something that you've probably heard discussed, you've heard many times in sports about a concussion. So concussions fall under the classification of a mild traumatic brain injury. They either do not result in loss of consciousness, or someone will be unconscious for 30 minutes or less. And typically the symptoms appear immediately or within several weeks. We get into a moderate traumatic brain injury. This results in a loss of consciousness for more than 20 minutes, but fewer than 6 hours. Physical, cognitive, behavioral performance many times is going to be impaired for months and then potentially for life, depending upon what damage to the brain has taken place. Severe traumatic brain injuries are generally a result of a traumatic head wound, both closed head injuries and penetrating injuries to the head, resulting in unconsciousness, and it lasts longer than 6 hours. The more severe injuries that we're looking at here are going to result in significant damage to the brain tissue, and there's going to be a wide range of behavioral and physical outcomes involving most aspects of the person's daily life. So there'll be a lot more long-term disability related to this. As far as the causes, the most common cause of traumatic brain injuries are things like falls, motor vehicle accidents, being struck by objects, and physical assaults. So that's usually what's occurring. Again, in sports and athletics, usually the brain injury that's experienced is the mild traumatic brain injury, or we would be classified as a concussion. The issue with brain injuries is you have the initial damage and you have the secondary damage. So the impact or the actual injury itself, that's the initial damage, which can cause obvious problems just from the trauma. But altered blood flow and then inflammation that comes after that produces secondary damage. And it's usually that secondary damage that's more responsive to therapeutic intervention. So when if the tissue gets inflamed, there's changes in blood flow, that's going to create a situation of secondary damage, which can cause which is obviously going to cause cellular damage and things like that to the brain. And that is the one that's usually more responsive to the therapy. So looking at medications, there's no medications to directly treat the actual brain injury. They can use various drugs to treat symptoms related to the brain injury. So various pain medications, anticoagulants, antispasticity drugs, and anticonvulsants. One of the things that's known to be, because again of the use of opioid analgesics to control pain, it's going to be important because the side effects from them could also limit exercise capacity, obviously, which would be important for you to be aware of as an exercise professional, and what that would mean. So again, nausea, drowsiness, urinary retention, orthostatic hypotension are all things that could be experienced from the medications. Anticoagulants, for example, warfarin can cause an increased risk of bleeding. Anticonvulsants, which are also anti-seizure medications, again, there they could have fatigue, you could have digestive problems, dizziness, and blurred vision. And again, some other types of drugs that they may be placed on to control symptoms: antidepressants, anti-anxiety drugs, muscle relaxants, sedatives, and stimulants are all drugs that can be used to treat someone for traumatic brain injury. Again, make sure to review your table. The medication table for traumatic brain injury is table 8.5. Again, this will kind of outline some of these medications, their effects, side effects, and kind of how they would impact the person taking them. As far as the effects of exercise, aerobic training has been deemed safe and effective for people with traumatic brain injury. Again, you're going to improve various physical measures, peak power output, VO2. It has also been shown to reduce depression. Many times individuals who suffer traumatic brain injury, they through the kind of the loss in function that they have or some of the difficulties they face, many times end up suffering from depression. So that's something that can also be assisted with aerobic exercise. So aerobic exercise can be just as effective as it is for individuals without traumatic brain injury. So, on top of obviously improving those functional benefits and reducing depression, all the other benefits that individuals would get would be beneficial for that. They have looked at the safety for individuals with post-concussion syndrome that do treadmill tests. They were able to safely use treadmill tests to determine submaximal aerobic training zones. So, the aerobic exercise is going to be safe and is also going to be beneficial for them. Right now, there's currently no evidence in support of or against resistance training on individuals with traumatic brain injury. We've run into situations like this before with certain pathologies. Again, all it just basically means is that they really haven't done anything or nothing has been shown. So essentially, again, we all know there's benefits to resistance training. So obviously they'd likely get the same benefits as just a healthy person would who would be undertaking resistance training. So again, your exercise recommendations in table 8.5, just some things to kind of note. There's no specific recommendations for traumatic brain injury, but recommendations for older individuals can be used with modifications. Once these individuals are given medical clearance, people with traumatic brain injury can participate in training, but instructions should be given clearly and multiple times. And again, part of that is because of the fact they've had a traumatic brain injury. Obviously, memory can become, memory and comprehension could become a problem for individuals when you're looking at this. Again, there might need to be other modifications because you might have to look at things like motor deficits and balance impairments as being issues that you have to contend with. So you may have to modify exercises. You may have to make sure, obviously, that the facility or wherever they're exercising is safe for them to train in. Just some other general suggestions. Usually the aerobic training is going to start at a lower intensity. If the individual does have some upright stability problems, stationary cycling or rowing could easily be used. So again, just find a mode of aerobic training that maybe early on can be beneficial. We always talk about being weight bearing many times for people, and that's good. A lot of the neurological conditions, this being one of them, is a situation where, they might have problems with stability and then getting fatigued on top of that, making it even worse. So certainly the stationary cycling or rowing could be used. Again, resistance training could have benefits. There's no specific protocol. So basically you could base your your programming guidelines on modified versions of what would be recommended for just the general population, to be able to create to create the resistance training. And again, in a lot of instances, particularly early on, those individuals will have to start at a lower intensity. So, again, look at table 8.5 for the resistance training. They do tend to start with these individuals, again, a lighter approach, 50 to 60% of your 1 rep max. And many times they'll sometimes start with some single joint exercises, again, because of the possible balance issues and things like that associated with this. Okay, next we're going to move on to stroke. So stroke's a vascular event where you get loss of neurological function related to an acute interruption of blood flow to the brain. And there's going to be 2 main types that we talk about here. One is the ischemic stroke and the other is the hemorrhagic stroke. So the ischemic stroke is usually going to be caused by some type of blockage, whereas a hemorrhagic stroke occurs as a result of actual bleeding into the brain. And again, in either one of these cases, you're going to have a situation where that region of the brain experiences damage, and that's where a lot of the person's deficits are then going to come from. There is another form of stroke, also known as a mini stroke. That's what's called a transient ischemic attack, and this is usually the result of a temporary blood clot that kind of goes through the circulation in the brain. The important thing to note here, again, just in looking at the physiology, the nutrients for the brain functions aren't stored in large amounts in the brain tissue. So the amount of time where blood flow is blocked to a region of the brain is very crucial. And a stroke on one side of the brain is going to produce deficits on the opposite side of the body. So if you have a right-sided stroke, there's going to be paralysis on the left side of the body. Usually that's going to also cause problems with vision and memory. And if you have a left-sided stroke, that's going to cause paralysis on the right side of the body, and that usually also includes limitations in speech and memory loss as well. And then you also look at when you're talking about paralysis on one side of the body, we refer to that as hemiplegia, if there's paralysis on one side of the body. So there's a variety of factors that could predispose some individuals to stroke. Here you have smoking, high blood pressure, inactivity, obesity, age, hereditary, and race. Ischemic strokes are going to be caused by either thrombosis, embolism, or global ischemia. So thrombosis is a blockage of a brain vessel, and it's usually from a buildup of fat and cholesterol in the blood vessel lining. An embolus is a clot that travels to and lodges in the brain. So, the thrombosis will form in the brain. The embolus is going to travel through the bloodstream and kind of lodge itself in the brain. The global ischemia is usually going to occur because of whole body ischemia from a heart attack or from some sort of catastrophic loss of blood pressure. So that would be another reason that would cause that. Hemorrhagic strokes are caused by a rupture of a blood vessel because of damage to the vascular structure. Things like cerebral aneurysms and chronically high blood pressure. If you're not aware of what an aneurysm is when you get weakness in a blood vessel. So what will actually happen is the blood vessel has kind of like a weak spot in it. What will happen is it'll kind of balloon out, and that'll eventually rupture and cause bleeding into the brain. So looking at your medications, and again, refer to the medication table 8.6 for stroke. Blood thinners, including antiplatelet drugs and anticoagulants, are administered to reduce the chance of additional clot formation. Again, the issue, as we've discussed before with these types of drugs, is there's a chance of bleeding complications, and they may be a reason to avoid vigorous physical activity. So depending upon the blood thinner, it may limit their ability to perform physical activity. Blood pressure medications, if it's perceived that that's the problem. So hopefully by now, see, you're starting to see, so here's something to note. You're starting to see repeat medications. So whether it's, the actual name of the medication or the class of medications, many of these are being repeated. So hopefully you're able to make the connection, for instance, that ACE inhibitors, beta blockers, calcium channel blockers control blood pressure. Kind of start to take note as you're starting to see repeat names and you go through. Again, many times stroke victims have various comorbidities, and that's usually what many times the medication is going to be used to address. So again, things like hypertension, high cholesterol, diabetes are all going to be reasons why, and possibly predispose somebody to a stroke. So in looking at the effects of exercise, one thing to note that after a stroke, the causes of death are usually recurrent strokes and things like coronary artery disease. So if an individual is inactive following a stroke, that's going to predispose them again to further complications or having another stroke. So again, the physical activity component being very important. However, obviously the stroke is going to have significant impacts on activity. So exercise intolerance as a result of a stroke and many of the after effects can cause a lot of deconditioning and gait inefficiency. So clinical exercise program will look to improve a lot of those things, and many times an individual will be receiving usually therapy to kind of directly address a lot of those. Most of the recovery is going to take place within about 9 months. And then after that, we look at aerobic training to help improve aerobic capacity, similar to those without stroke. And then what that can then do is reduce the energy cost at submaximal effort walking. So what that implies is they'll have improved gait efficiency. So again, after the stroke, really not only just exercise tolerance, but just physical activity in general, they're not going to have the same tolerance for it. The aerobic training will kind of help with that. So once they've kind of gotten through any type of therapy to improve on those neuromuscular deficits, then the aerobic training after that, in addition to limiting other comorbidities or decreasing the chances of having another stroke, will all be beneficial to them. We're still looking at the effects of exercise. So the use of the treadmill with handrails or a harness can be used to help control the loading and intensity of the exercise during recovery. And again, resistance training, improves strength, power, muscular endurance, neurological adaptation. At lower body resistance training at a higher intensity, around 80% of a 1 rep max, has actually shown to be, has actually shown significant improvements. And one thing to also particularly note is that the hamstrings tend to be weakened in the paretic limb. So again, making sure to really work hard on the lower extremity strengthening can be very beneficial. And again, you may want to go to higher intensities. So, and again, the hamstrings in particular, so give special attention to, knee flexion and hip extension in improving their lower body strength. So again, you could look at other recommendations. We'll summarize some things. Again, aerobic training can use arms, legs, or both. You have your intensities here given as a suggestion, and your progression that you could include with that. Again, you may have to start with shorter sessions at first for these individuals, and then gradually progress them. Resistance training should be similar to that of programming for the elderly. Unilateral movements involving the affected limb should also be used. Again, obviously, you may have to progress them, as far as the, how difficult the exercise variation you would use. It would be important to make sure that you progress them appropriately. You might have to start with lighter resistance, but you would want to look to progress to, the 60 to 85% range, particularly for the lower extremity, to really help the neuromuscular adaptations for these individuals. And again, the equipment you're going to use is going to be guided by their motor limitations. Again, there's a wide variety of physical functional limitations that could come out of this. So again, you may have to utilize different types of equipment as we look at here based upon their functional deficits. Grip strength can be enhanced utilizing special mitts. If by chance they can't hold on to things, they could certainly get assistance with that. And again, use resistance training machines with good torso support or chest straps if need be. And again, if progress dictates, chest straps can gradually be removed. So, look to adapt the equipment, and you could certainly get insight from the other from the medical professionals who are involved in their treatment as far as things that could be beneficial for these individuals while they're doing their exercise. So looking at spinal cord injury, so again, this is an injury or disease process of the spinal cord that results in either altered motor, sensory, or autonomic functioning. So injuries to the cervical region are going to affect the upper and lower extremities as well as the trunk, producing what we call a state of tetraplegia. The term that used to be used and sometimes still does get used is quadriplegia. If you have injury to the thoracic or lumbar levels, that will produce what's called paraplegia or deficit in the lower extremities and some portion of the trunk. So essentially what happens is whatever level you have damage at, it's that level and everything below it that will have some degree of loss. The designation of injury is going to get described as the vertebral level of the spinal cord injury and the completeness of the functional deficit. So in other words, depending on how much of a functional deficit they have, if they have complete total loss of all functions, they will deem it complete. Whereas if it's what's called an incomplete lesion is where there's some preservation of either sensory or motor function below the level of the injury. So just in discussing some things related to spinal cord injury. So again, the spinal cord is protected by the vertebral column, but injury can still occur even when the vertebrae are intact. So, a fracture of a vertebrae doesn't necessarily have to happen to the, in order for there to be damage to the spinal cord. An injury can be a transection where the cord's just completely cut, or what we call a spinal cord contusion, which is essentially just a bruised spinal cord. And again, one versus the other will have different degrees of damage. Another thing to note is that many times after the initial injury, more damage could happen due to swelling and inflammation. So much like we talked about with the head injuries having the secondary injury occur, that's another thing that can also happen with spinal cord injuries, is that you can have further damage due to swelling. So that's one of the things many times that a lot of immediate treatment will look to minimize. Many times in an acute setting, a physician will administer methylprednisolone, which is a steroid to help reduce inflammation in those cases. So this is something that will come about. Another thing that was mentioned in your textbook, and I think it's important to mention just from an activity perspective, something called autonomic dysreflexia. So what autonomic dysreflexia is, it's a very serious condition that someone with a spinal cord injury can develop. And what essentially happens is that if there's any type of noxious stimuli applied below the point of the spinal cord lesion at the T4 level or above, it'll produce an increase in heart rate and blood pressure that can be potentially life-threatening. So that's an important thing to kind of keep an eye out for. Actually, some wheelchair athletes will actually sometimes try to induce it on themselves, almost as like a performance-enhancing thing. However, note that it is a very dangerous thing to do. So that's one important kind of term to kind of be aware of as we're dealing with individuals with spinal cord injuries. As far as your medications go when you're looking at spinal cord injuries, so again, medications are usually going to be prescribed to treat symptoms. So there's no pharmaceutical method that can be used to actually reverse spinal cord injuries. Other medications, tricyclic drugs and selective serotonin or norepinephrine reuptake inhibitors. And those are actually medications, again, typically used to treat depression, but they can also be used to treat neurogenic pain, which individuals with spinal cord injuries could sometimes experience. So they will be used typically for that, for that actual function. Again, side effects for various medications: nausea, drowsiness, sedation, lightheadedness, dizziness, muscle weakness. And again, those are things that will impact the individual's ability to either exercise or maintain balance. So obviously those are some things to keep in mind with those particular medications. Some other medication issues: ditropan for bladder control, depression and autonomic dysreflexia. Again, that can produce dizziness, weakness, and drowsiness. Other antidepressants, again, Prozac, Zoloft, Wellbutrin, again, can produce dizziness, fatigue, and nausea. If an episode of dysreflexia occurs while a person with spinal cord injury is on medication, medical assistance should be sought immediately. So again, that could produce the autonomic dysreflexia. I had already talked about this. That produces an extremely dangerous increase in heart rate and blood pressure that, if not dealt with, can can possibly cause death. So that's one of the big things you do want to watch out for when you're dealing with spinal cord injuries. Again, refer to Table 8.7 for a little bit further explanation or just an outline of these medications as we've discussed. So if you look at the effects of exercise, again, autonomic dysfunction will limit the capacity due to cardiovascular limitations and is present with complete spinal cord above the T4 level. So at above the T4 level, your functional capacity is going to be limited severely because there's going to be autonomic dysfunction related to your cardiovascular functions. So again, this is going to be some of the things you want to look at and be aware of so you know your different levels. This is, again, too, where the competitive wheelchair athletes will sometimes try to induce the autonomic dysreflexia, which, again, is a very dangerous practice and is something you want to keep an eye out for. Increases in VO2 max have been demonstrated with moderate intensity arm crank ergonometry work. So again, this is something that will be of benefit for individuals. So again, you may have to use, obviously, different forms of exercise for these individuals due to their functional limitations. High-intensity upper body resistance training paired with low-intensity arm cranking has been shown to improve strength significantly. In addition, venous return from the paralyzed limbs will be impaired with these individuals requiring a higher level of oxygen extraction, leading to early local muscular fatigue. So that's going to be something that's going to limit their exercise capacity as well, is this limited venous return. If you think about, in individuals that can walk and have full function, they get venous return from their lower limbs. Well, if someone's in a wheelchair and can't use their lower limbs, they're not getting as heavy a venous return from their lower extremities to kind of assist with that blood flow through the extremities. So that is something to bear in mind for these individuals as well. So your exercise recommendations, again, I encourage you to take a look at the table as well, but just to make some note of things here. Aerobic training, 1 to 3 sessions per week, 15 to 30 minutes per session. Again, you have around a 30% to a little less than 60% of your VO2 or heart rate reserve, or again, you can use the rating of perceived exertion of 9 to 13. Training modes usually going to be limited to arm crank exercise or reciprocal press pull exercise. So again, you're probably going to have limitations where they can't use the lower extremity, so they're going to have to use some type of mode of upper body training for the aerobic work. Resistance training should be done at least once per week at first. Again, start pretty light and gradually start to increase the intensity of the movements over over time using multiple sets. So again, you're going to want to be familiar with the level of the injury and assign exercise as appropriate. So we're going to go over the different levels, and I do want you to at least have a basic awareness of the different levels and kind of what that is going to mean, because that's going to be an important thing when looking at individuals with spinal cord injury as to, you know, what their deficit's going to be. Rule of thumb is wherever the injury has occurred, it's going to be everything below that that is going to be affected. And again, obviously, it also too depends whether you're dealing with a complete or an incomplete spinal cord injury at those different levels. Be careful not to overload the available musculature, okay, particularly for the fact that you know, they're going to have to do, you know, wheelchair transfers and things like that, so that leads them to the susceptibility of overtraining. Exercisers should use antagonist muscles to those that are used in daily movement. So, you know, again, think of what they have to do with their day-to-day based upon their functional deficits and make sure to work those antagonists. Torso stabilization is going to be difficult, so you may have to use stabilization devices. And again, you may have to use machines modified for wheelchair use. Wrist straps can also be used to overcome grip weakness. If that's an issue for these individuals as well. So here's a graphic from your textbook, and again, you can look at it in there as well. So essentially, when you're looking at these different levels, so you have your cervical vertebrae, your thoracic, your lumbar, and your sacral vertebrae. So again, tetraplegia, anytime you have any injury to the cervical region, you're going to result in either complete or incomplete paralysis of the arms and legs. And then anything below that, you're going to have, you know, complete or incomplete paralysis of the legs. Again, you also want to be aware, depending upon if they do have damage at the thoracic level, again, you also have the concern with the autonomic dysreflexia as well. So these are the kind of the different levels that you could kind of see as far as the different levels related to the spinal cord. So, you know, for instance, when you're looking at, you know, someone with a, you know, a partial or complete paralysis of the lower arms and hands, you know, which again, there you'd be looking at someone with damage at the cervical level, they are going to have limited gripping ability. So those individuals would want to use either, you know, specialized mitts or gloves or straps to be able to help them grip and be able to work some of the musculature while they're you know, while they're dealing with their problem. And again, as a reminder, you know, again, the persons with cervical spinal cord injury or with paraplegia above T4 are at risk for autonomic dysreflexia, which again, it can be life-threatening. So that's something you're going to want to be aware of as well. Again, that's going to cause that dramatic increase in heart rate and blood pressure. And I had mentioned before, I guess I should explain this. I mentioned before, the autonomic dysreflexia is going to occur from a noxious stimuli, and that could range from something as small as like a blister occurring on the body or an overfilled bladder that can possibly cause the autonomic dysreflexia. So, you know, for instance, if they hold or don't go to the bathroom or empty their bladder, that can actually cause an autonomic dysreflexia. If that is to happen, then that is something that needs to be dealt with immediately. And they should be transported to a medical facility for that. All right, so now looking at epilepsy. So epilepsy is a collection of disorders characterized by recurring seizure activity. So seizures essentially happen because of an excessive electrical discharge in the brain that kind of disrupts a normal brain pattern. They're going to have a variety of outcomes. So there's various types of seizures. I'm going to talk about kind of the primary classifications we're going to discuss, but they present in various ways, ranging from literally just blank staring, where the person will just kind of stare off into space, it almost seems, for a short amount of time, to someone that goes into jerking movements, convulsions, possibly leading to unconsciousness. It just depends upon the brain area that gets affected. And again, the duration of seizures could range from seconds to minutes. You know, from a medical perspective, in sports medicine, we're taught that you should try to time the seizure if somebody has one. And speaking from experience, even a seizure that happens for a short amount of time seems like a very long time when you have an individual who is having a seizure. Now, epilepsy itself kind of gets diagnosed and sort of defined as the following. So this is kind of because again, just because you have a seizure doesn't mean you have epilepsy. Okay, so epilepsy is kind of the disorder if you have recurring seizure activity. You could have a seizure but not have epilepsy. So they define it as the following: at least 2 unprovoked or reflex seizures more than 24 hours apart, 1 unprovoked or reflex seizure, and the probability of further seizures similar to the general recurrence risk after 2 unprovoked seizures occurring over the next 10 years. So that's how they kind of diagnose epilepsy syndrome. So again, just because you have 1 seizure doesn't necessarily mean you have epilepsy. There's that diagnostic criteria for actually having epilepsy. So again, more severe seizures are going to exhibit like that uncontrolled, uncoordinated convulsions, whereas less severe seizures, as I had talked about many times, just involve maybe like blank staring. Lip smacking is also another thing you'll commonly see people kind of do. When, as far as the classifications, they're classified as either primary generalized or partial focal. So the primary generalized seizures involve both sides of the brain, while partial seizures only affect one part of the brain. In addition to the diagnostic criteria I talked about, to diagnose someone with epilepsy, they'll usually include various other tests, blood work, medical history. They'll do a full neurological exam, CT scans, MRIs are basically some of the tests that will get run. Again, some of that just to make sure that there's no other thing causing within the nervous system or any other type of disease or illness that's producing seizures, because there are other things, again, that could produce seizures beyond someone just having epilepsy. So seizures can be brought on by eating certain foods. So again, there's triggers to epilepsy for people to have seizures. Again, changes in hormones, stress, sleep patterns, these are all things that can do this. As far as the cause of epilepsy, it's unknown. It could be related to a head injury. It could relate to brain damage during birth, brain tumors. So again, that's part of the reason why they do a lot of the studies that they do, just to make sure, try to find, what the cause could possibly be. And again, determining the source, if possible. Again, you may not determine an exact source. It's not uncommon. Again, someone will get diagnosed with epilepsy and they don't have a source, to help determine the appropriate treatment for these individuals. So as far as the medications are concerned, again, obviously the anti-seizure, anti-epileptic medications are going to be the most common, and these can help control seizures for a large portion of individuals that have epilepsy. Side effects include fatigue, dizziness, blurred vision, behavioral changes, and depression. And many times, that'll actually be something, I know from an athletic training sports medicine standpoint, that's something you have to watch. If you have an athlete that has epilepsy, sometimes they'll stop taking their medication because of the side effects, and that's something that you certainly have to watch with those athletes, is that they don't stop taking their medication, because that obviously can allow them to increase their chances of having a seizure. Weight loss can necessitate a change in dosage. So if you are working with somebody that has epilepsy and they do lose weight, that's something that should be, communicated with the physician, because of the fact that they may need to change the dosage of the medication that they're taking. You can refer to the medication table on 8.8 to kind of take a look at, again, just be able to recognize the names that they're of the medications used to treat epilepsy. As far as the effects of exercise, so again, people with epilepsy many times are going to have a lower resting metabolic rate and resting oxygen consumption, but a decreased EEG activity following exercise. So EEG is referring to electroencephalographic response. So again, when they have during and following exercise, there's decreased activity there. So again, individuals with epilepsy having that is a positive effect. So again, in addition to the positive effect on the electroencephalographic response, you also have, again, the benefits of improving their metabolic rate with exercise, because people with epilepsy do tend to have a lower resting metabolic rate. Now, even with the decrease in electroencephalographic response, exercise does not decrease the rate of seizures per se, but it does improve the overall health and quality of life of the individual. So, and again, some of that directly relates to improving the resting metabolic rate. Plus, it's just, again, the overall feeling of wellness. Again, sometimes, again, with a lot of other conditions, when people get diagnosed with something like this or have one of these issues, mentally it's tough on them. And being able to exercise obviously, improves their overall well-being. So it's really important in order to do that. In addition to the other physical benefits, it's a benefit for these individuals to mentally be taking part in physical activity and exercise. So as far as your exercise recommendations, the primary concern is a seizure during or immediately after exercise, but interestingly enough, exercise-induced seizures are actually very rare. So these usually do not, these typically don't happen a whole lot when an individual is doing things. So the exercise prescription is similar to that of a deconditioned adult. So many of the recommendations, if you go and look at them, are very similar to a lot of those other conditions where there's nothing per se that really holds them back, where there's no major issues. The resistance training is that, they can work up to that 60 to 85% of a 1 rep max. If need be, you could start them out at a lower intensity. Again, light to moderate intensity aerobic activity, that 30 to 60% of VO2 or heart rate reserve, rating a perceived exertion of 9 to 13, all of that will work pretty well for these individuals. Again, you should be familiar with first aid procedures, and there tends to be a lot of confusion with this. It should be noted that if you do have somebody, so again, exercise in many cases doesn't necessarily trigger a seizure unless they get overly fatigued, which again, as the professional, you should be able to kind of monitor that. In the case that an individual does have a seizure, okay, the basic first aid, again, they don't necessarily last long. Usually they tend to end naturally. It will seem, again, I'm speaking from experience, it will seem that it is taking longer. When someone is having a seizure, it does, again, seconds seem like minutes, but you should not try to stop them. Do not try to restrict their movement. Do not put anything in their mouth. The one thing you do want to do is just protect their head from injury. Make sure there's nothing that they could hit or run into. So kind of, do your best to just kind of clear the area, but do not try to restrict their activity. Do not put anything in their mouth. Don't give them anything to eat or drink until they are fully conscious. Many times after the seizure is over, they do tend to be disorientated and tired. It does take a lot out of them. Make sure to give them sufficient rest before expecting them to move. During what's called a tonic-clonic seizure, so during a tonic-clonic seizure, the person will lose consciousness, their muscles will stiffen, and they'll have the convulsions. Clients may stop breathing during the tonic phase, but are often able to breathe again during what's called the clonic phase. If they don't resume breathing, CPR or rescue breathing should start immediately. Clients may also vomit or have incontinence during a tonic-clonic seizure. Again, to prevent choking and aid in breathing, you can position them on their left side. That may be beneficial to them. You would call EMS if a person is having difficulty breathing, if they've had a seizure that lasts longer than 5 minutes, if they've had multiple seizures without regaining consciousness, or if they're pregnant, injured, or diabetic. All of those situations would require you to call EMS. And again, a seizure that lasts 5 minutes is going to feel like a really, really long time. And that would be a situation where you would call EMS. If there are frequent seizures, they should avoid exercise that might result in an injury if a seizure occurs. So again, watch certain weightlifting activities, treadmill activities, and water activities if they are having frequent seizures or they're not controlled very well. And these are your various learning outcomes related to. So again, when you're studying, I always talk about this, but I'll throw this in here again. People always say, well, what should I study? Again, look at your learning outcomes. So, pick a learning outcome, see what you can recall based on that learning outcome. So for instance, the first learning outcome here, describe and list physiological characteristics and various neurological disorders. So first of all, can you list all the neurological disorders that we talked about without looking at your book? And then can you list physiologic characteristics of each one of them? That's a good starting point. Okay, can you do that? If you can't list all the conditions, then you know that you need to study. Obviously, you need to study more because you can't just list the conditions. Okay, so that's a starting point. So that's the reason that's why these learning outcomes are listed. I don't put them up here just to put them up here. I put them up here for you to look at them to help with your studying and for the learning process. And that concludes the neuromuscular conditions and disorders chapter.